Manual way?
Dr. Fox, was it due to the Hodgkin's treatment?
It was actually due to the treatment from it.
The treatment for Hodgkin's,
Yeah.
okay.
And even that's unusual today for that. I mean, it can come, you know, it can be seen in cancer patients just because a lot of the cancer therapy stuff, like chemotherapy, is immunosuppressive. All right. So do we have any density change here?
Yes.
Okay, upper right lung, and there's actually two kind of density changes here. Agreed?
Yes.
Because wouldn't you say it's more dense here, still increased, but less dense laterally? Okay. There's also a border right there. You see that? Okay. Let's focus on some other things. Where's the hilus sitting? Right in here. I don't like the level of it. I think it's higher than this one, don't you? Is it supposed to be? No. It's supposed to be lower, exactly. How about the diaphragm? Yeah. And it's higher on the side of the increased density. So that means you got the hilus and the diaphragm both going up, right? This may very well be the what? Minor fissure, which is supposed to be down here. It's going up. So we got fissure, hilus, diaphragm, maybe even very slight tracheal, all going toward the increase in density, right? So it certainly sounds like a little bit of volume loss, doesn't it? So how do we account for the two densities? More opaque here, a little bit less here. Well, actually, if we kind of forget this for a moment, this little bit of increased density, which may even have a bit of vascular crowding here, is probably about what we get by taking the minor fissure from there to there, which is not a great deal of movement, but it did move. So this density, this greater density, is actually a combination of this plus whatever this is giving us. If this is moving up, this is going up, this is going up, this is going up, what's losing volume? Which lobe?
Right.
Right upper lobe, exactly. Right upper lobe. Okay. So is that going to be resorption, passive, or cicatrix atelectasis? Resorption, exactly. So where's the obstruction?
In the main bronchus. The lobar bronchus.
Yeah, right upper lobe bronchus. That's where the obstruction is. If it was in the main stem bronchus, the whole lung would collapse, exactly. The whole lung would collapse. Then you don't get any fissure movement, but you do get a lot of movement of the other structures. Because if you start shrinking the whole thing, this is going to move, this is going to come up dramatically, rib interspaces are going to narrow, the whole thing's going to start moving, isn't it? So we have an obstruction in a right upper lobe bronchus. If it's an adult, carcinoma has to be right up at the top of the list. So what's actually happening is this is part of the tumor density. So we're not getting hilar enlargement. So if you think of the main stem bronchus as a little tube, and the tumor started inside the bronchus, and it grows from the epithelium, the lining of the bronchus. There's enough of the tumor growing inside the bronchus to obstruct part of the air. But the bulk of the tumor is growing out away. It still started in the bronchus. There's enough in it, but most of it's growing out away. It's like the iceberg. You know, you got a little bit of it here, most of it grew out away. Sometimes the thing will just sit there and enlarge. But this one grew out away from the bronchus. It's still attached to the hilus, but that's why we've got density going up here. This is actually tumor. Then you've also got some of the increased density from the lung. Once we're lateral to the tumor, that's the actual atelectasis density, increase in density. So that's why it's done that. And this is really more more likely to be one of the central tumors, which is typically squamous, small cell, classically central, but I think this one ended up being an adeno, which is a little bit unusual because adenos are more likely to be peripheral. Yeah, this proved to be an adenocarcinoma, right upper lobe bronchus. And the reason I say it's a little atypical because adenocarcinomas are more commonly in smaller bronchi. So if you just think, when we talk about tumor, which we're going to here real quick, central versus peripheral, which we're going to focus on a lot. Central tumors are right around the hilus because they originate in a big bronchus. So if it's a main stem bronchus or a lobar bronchus, it's going to be right at the hilus, isn't it? If it's in a sub-segmental bronchus, it's going to be out away from the hilus, isn't it? So that's a peripheral tumor. Central tumors at the hilar area, or in some cases, if it's a main stem bronchus, it's even going to be in the mediastinum, isn't it? That's classic of a small cell tumor to do that. So where it's located, central or peripheral, can help, at least in thinking about what the cell type might be. But this one was an adeno. And if it's a patient, if they're over 40 and they have resorption atelectasis, tumor is at the top of the list. Until somebody says, no, it's not. It's this. I mean, even asthma can do it in an adult or a foreign object. But tumor is such a common cause in adults.